Hello, and welcome to the Clinical Care Options Medical Specialties Podcast. I'm your host, Joshua Schechtel. Today's episode features a conversation with four experts in Alpha-1 antitrypsin deficiency: gastroenterologist Dr. Rohit Loomba from UC San Diego, allergist Dr. Paula Henao from Penn State University, pulmonologist Dr. Cheryl Pirozzi from the University of Utah, and nurse practitioner Corinne Young from Colorado Springs Pulmonary Consultants. They are talking about how we can better diagnose and manage patients with Alpha-1 antitrypsin deficiency. For more information on our speakers, along with a link to more resources, please visit the show notes for this episode. Now let's get started and hear what the experts have to say about this important topic.
At UCSD, what we do, and this is typically what we would expect, any patient who comes with elevated ALT and AST, that's typically one of the reasons why somebody would get referred to our clinic. And usually it's been elevated over at least 6 months time period. That would be a patient that we would at UCSD evaluate for Alpha-1 antitrypsin related liver disease as a etiology for elevated ALT and AST. Now, of course, people who do not do that probably think about that it's a rare disease. So, probably start with things that are much more common. And the common things would be, thinking about whether somebody has viral hepatitis, so hepatitis B, hepatitis C, autoimmune liver disease, and looking for ANA, as well as, iron overload, looking for ferritin, and then thinking about fatty liver disease, whether it's due to alcohol or related to metabolic syndrome or obesity-associated fatty liver disease. So I think within that spectrum, the reason why we do it is because we don't want to be missing out on diseases that our patients may have because we are a tertiary care center. So that would be definitely one group of patients that we would do. I think it'll be totally reasonable if somebody did in a sequential manner that if viral hepatitis was negative, then this could be the second set of tests if that's how they want to do it. The other patient population where we have a high likelihood of testing for Alpha-1 antitrypsin related liver disease is somebody who already has a diagnosis from a pulmonary colleague for Alpha-1 antitrypsin related lung disease. So they may get referred. Now they already have a disease diagnosis. Typically, I will still, because many times they've been followed for many years with pulmonologists, they may not have a record of exactly what their genotype is or their phenotype is. So when they come to my clinic, I order levels, Alpha-1 antitrypsin levels, I order phenotype, and if genotype is available, I order a genotype. And this way we are able to establish the diagnosis, whether it's ZZ disease or MZ or another pattern. And this way, we can inform them about their risk for liver disease. Another group of patients who might come is somebody with COPD and emphysema as past medical history, and they have either elevated ALT or fatty liver on ultrasound or any other reason they might be seeing me. So if they have a history of lung disease, and particularly emphysema, I am extremely likely to be doing testing for Alpha-1 antitrypsin levels and then, phenotype or genotype. So I'll stop here and see what my pulmonary and allergy colleagues do.
My impression is that the gap in diagnosis probably comes more on the pulmonary side. In my opinion, at least at our institution, I feel like the hepatologists are very consistent about screening everybody with unexplained liver disease for Alpha-1. But the guidelines call for screening in anyone with COPD, anyone with poorly controlled asthma, which are very common conditions. And so I think, among primary care providers or even pulmonologists and allergists, I think a lot of times those patients are not screened unless they have very classic Alpha-1 findings, like out of proportion emphysema, they're younger than expected, they have lower lung pan-acinar emphysema. But the reality is that it can look like typical COPD. And so I think a lot of times screening isn't done when it should be.
We'll quickly echo Dr. Pirozzi and Dr. Loomba. Really, as Dr. Pirozzi mentioned, most of the patients with COPD are not screened. One study showed only 5% of patients with COPD are screened for Alpha-1 antitrypsin deficiency, even though the guidelines really show that all patients with COPD or emphysema should be screened. In addition, with those with asthma and irreversible airflow obstruction, certainly unexplained liver disease, necrotizing pancreatitis, unexplained bronchiectasis, or a first-degree relative with alpha-1 antitrypsin deficiency. From my perspective, the biggest issue with alpha-1 antitrypsin deficiency has been our inability to really screen people appropriately. And when I talk to colleagues in other fields like primary care, we really don't have a great understanding of when screening should happen. And it seems like, oh, I'm not going to screen every COPDer. That seems unreasonable, even though there's free screening by the Alpha-1 Foundation. The studies from the Alpha-1 Foundation showed that their free screening kits were capturing abnormal alleles in 14.6% of the patients screened, which is, they're capturing a huge volume of problematic alleles in the patient screen. So we're clearly not screening enough.
You had mentioned specifically about GI, but liver screening specifically, and being in pulmonary, I am not aware of if there are GI guidelines specific to that outside of abnormal LFTs, but if it's in their specific guidelines, I'm unaware of that. But anybody that comes to us that is being evaluated for Alpha-1, we're doing liver ultrasounds and LFTs, making sure they're getting their hepatitis vaccines, their titers are good, and then also, if they haven't already, been referred to hepatology or GI.
Yeah. One thing about liver disease evaluation, how often are you doing a fibroscan or a FIB4 assessment in your patients with alpha-1 antitrypsin, or the hepatologist at your institutions or in your area are doing it? Because that's something would be also important. Once we detect that somebody is, then we would want to see if they have fibrosis or not. Many patients don't want a biopsy, so some sort of a non-invasive assessment is reasonable. And so we are typically looking at their labs, the ALT, AST, platelets, and then, doing a fibroscan assessment or an MR elastography that's available.
So I get GGT, LFTs, and INR usually every 6 months, and also an ultrasound. I must admit, I want to get it every 6 months, but a lot of times in practice, patients don't want to go to get an ultrasound every 6 months. So I let them slide a lot of times and let them go for a year if they've had normal ultrasounds. I know the guidelines are a little bit iffy every 6 months versus a year, especially in those patients that have been doing well.
My practice has been to screen annually with labs, the same labs you all have mentioned, and get an ultrasound. I refer to hepatology if there's any abnormality, and then they usually coordinate the elastography test.
One thing I would say that you typically the ultrasound and then potentially AFP is needed in the setting of cirrhosis due to alpha-1 antitrypsin related liver disease. So you could do an ultrasound baseline. I agree, you don't need every 6 months or every year if the patient is non-cirrhotic. But, I think if you don't know that, then I think it may be reasonable, assuming that they may have more advanced disease than doing less for them. And because with alpha-1 antitrypsin related liver disease, particularly those who are ZZ, there is a high risk for developing liver cancer, particularly if they were cirrhotic. So once they develop cirrhosis, then our recommendation is with anybody with cirrhosis to screen with ultrasound plus AFP, alpha-fetoprotein, a blood test every 6 months. So suppose you had somebody with alpha-1 antitrypsin related liver disease, and then you referred the patient to me. I did a fibroscan, and fibroscan was 7 kilopascal. And that patient has a pretty low likelihood of having cirrhosis. So that patient doesn't need ultrasounds periodically. You could repeat a fibroscan, say every 1 to 3 years in that patient, because they have a mild disease. And if there's progression and when the liver stiffness reaches the cirrhosis range, then you can, think about doing annual or every 6 months ultrasound and AFP.
I monitor lung function. I do generally annual PFTs. If someone is clinically unstable, I might check more frequently at first, but then usually annual lung function tests. In terms of practicality, I think if you have someone who has very mild disease or no lung disease and has totally normal PFTs for multiple years in a row, I will often then spread it out a bit more. But the guidelines say annual.
Yeah, for us, from a liver disease perspective, I think first is a diagnosis establishment of, whether they have fibrotic disease or not. Typically, we would start with a non-invasive assessment. So you can start with a FIB4 the FIB score is below 1 or above 1 or below 1.3 or above 1.3. It gives you a likelihood of advanced fibrosis. So if it is below 1.3, low likelihood of advanced fibrosis. We'll also do a fibroscan or MR elastography. If the fibroscan reading is below 7 or 8 kilopascal, then they don't have fibrotic disease or low risk of fibrotic disease. The fibroscan is 20 kilopascal or higher, we think about cirrhosis. So somewhere in between, you've got various stages of fibrosis. So depending on where their liver stiffness might be, we will determine the potential frequency for their repeat fibroscan assessment. So you could, vary between 1 to 3 years for a repeat fibroscan assessment. Liver-related enzyme, if they're abnormal, you could probably assess them every 6 months or so. And at some point, probably consider doing a liver biopsy. One thing we've seen in patients with alpha-1 antitrypsin-related liver disease is sometimes their ALT and AST may be just above or just below the upper limit of normal. And most people may not recognize that. So an ALT of, say, 35 and AST of 30 is abnormal, but most labs would say AST upper limit of normal might be 35, somewhere like 40. So typically a normal AST is around 20. And so you can see that even within normal limits for patients' ALT and AST, they can harbor liver disease that is occult and progressing and nobody knows about it. And then it also gives an opportunity to look at our success of lifestyle interventions during those visits as well. So that's the monitoring. And, as Paula and Cheryl mentioned, once you develop cirrhosis, then we want to do a monitoring for hepatocellular carcinoma. That's typically done with ultrasound plus alpha-fetoprotein, a blood test every 6 months or so. And then we would watch them for liver disease decompensation. So they might get esophageal varices screening with an upper endoscopy. And if they develop ascites, so the ultrasound that's every 6 months that's happening helps with assessing for ascites, which is water developing in the abdomen due to portal hypertension. And then some patients with more advanced disease can be at risk for hepatic encephalopathy, but that's very, very rare when somebody has cirrhosis and decompensation. And we monitor, those patients will be in a liver clinic and being monitored by a hepatologist. Non-invasive assessment is helpful, is good, but it's all presumptive. So we assume that because they are ZZ, that the liver enzyme elevation is absolutely related to alpha-1 antitrypsin deficiency. And when we do the biopsy, we confirm that diagnosis. At the same time, we are going to rule out other causes for liver disease. So we can also determine concomitant liver disease. So if this patient also had fatty liver disease, whether it's due to alcohol or whether it's due to metabolic dysfunction associated steatohepatitis or MASH, your biopsy will confirm that. The pattern of injury that we see with alpha-1 antitrypsin related liver disease is very different than the pattern that we see with fatty liver disease. So we can distinguish as to what is the driving force for this patient's liver problem. And so biopsy can be helpful. And biopsy is also helpful in excluding other causes. For example, is there iron overload? And so we can assess for that. Is there autoimmune liver disease? We can assess for that. So it can be helpful either in ruling out, confirming the disease, and finding concomitant liver problems that could be very common.
I think education is huge. I personally work a lot with trainees of all different levels, medical students and residents and fellows. So we do a lot of training for those groups. And then I think educational programs for primary care providers, pulmonary providers, allergists, and hepatologists too. But I think just education, even within my specialty, most people do not know or remember that you're supposed to screen everybody with COPD for alpha-1.
There's so many pop-ups that happen. You just want to get through your notes or something like that. It may help some people, it may not help others. I know with like lung cancer screening, we have a pulmonary nodule clinic as well. One thing that has helped our community-based practices, our primary care docs, is that there'll be a little blurb at the end of the report noting that there are these small incidental nodules and to consider the Fleischner guidelines and recommendations for screening based on the nodule size and the patient's. So they kind of note that in the results. So it may be, beneficial if there is a primary care with forward thinking to do alpha-1 screening, when they get the test results, could there be a little blurb at the bottom to consideration for LFTs, liver ultrasound, lung function testing, referral to a CRC or pulmonologist or a GI specialist, something along those lines. It was almost like a checkbox for them in the results section.
The Alpha-1 Foundation has done a really tremendous job in terms of trying to increase screening, and they've done a great job in terms of providing. I don't know if you guys use it. We do the free screening from the Alpha-1 Foundation routinely in our practice. Being able to have that more readily available for primary care doctors would be really helpful, because I think screening, if it's a costly test, like if you're getting levels, that's very expensive for patients. And so that might not be reasonable. But the free screening, I think, is a great thing. I do think that potentially doing more research on who to screen is critical. So right now, I think primary care doctors see these current guidelines and they don't buy it, to be honest. I've had conversations with a lot of primary care doctors saying, I'm not going to screen every patient with COPD. That's nonsensical. So figuring out if there's some models of who are the patients that are going to be highest yield for screening, that would be very effective, I think, in terms of getting more buy-in from other physicians for wider screening practices.
Particularly, I think it should be like clinic specific, so we can understand the yield. So, for example, in your clinic setting, so people could take a look at what the yield rate would be if you were to screen 100 patients, you'll find 2 or 5. And then same thing, and Cheryl, in your clinic with COPD or with asthma, I think those would be very helpful. And Corinne, you also mentioned that you have other pulmonary etiologies, and it could also be different. Those coming to see you at the university or the community-based sites, because the prevalence might be different. Regionally, of course, there'll be enrichment at more tertiary care centers. And then we can certainly increase the yield by, adding additional risk factors, say family history of cirrhosis would be something, because it's an important genetic cause for cirrhosis. So that could be something, particularly if somebody had lung disease and liver disease in the family. So I think family history is an important component. And then if you have your brother, sister, mother, father, Alpha-1, that you should be tested as another area. And I think that also can be assessed.
When I see a new patient with Alpha-1, I will talk about the genetics of it and, how it affects family members, and then offer screening for family members, usually through the Alpha-1 Foundation, because that's an easy send out, but at least have that education. Because I think even if you're seeing someone, I often will see someone who's heterozygous, a carrier. It's not really clinically a severe deficiency, but by identifying this one person, you then identify a whole family, and there are sometimes people with more severe deficiency and more significant clinical disease.
For us, it's an in-house conversation. We don't really use genetic counseling for Alpha-1 antitrypsin.
Resources are limited. So we tend to, focus on if they have liver disease and how much they have, and if there's a family member, who may have occurred liver disease. So really the focus is that. Genetic counseling in terms of, what their long-term lifetime risk of developing cirrhosis might be. The other reason is that you have time, in the sense that if you can catch it early, you could really, it's a slowly progressive disease, so you can, by lifestyle changes, really augment the natural history of liver disease progression.
We use services like pulmonary rehab, for the patients have pulmonary manifestations, they get pulmonary rehab referrals, the co-specialty, if we think there is some concomitant liver disease, they'd go GI, but I think for the most part, it stays in-house.
We have a medical bariatrics program that either I or often the hepatologists will refer people to who have fatty liver disease, and that could be really helpful.
I think the risk of liver disease progression by having another liver disease is significantly higher with Alpha-1 antitrypsin, particularly in ZZ or even MZ. So I think what patients don't know is that the damage they can have to their liver with, say, obesity or type 2 diabetes or excessive drinking is much more than an average person. And I think that's the sort of knowledge. If you provide that to the patient, the likelihood of them making that change in their lifestyle is much higher. And so to me, I think that's really the most important thing, that reversing that discussion that, if you didn't have alpha-1 antitrypsin related deficiency, then your risk would have been an average risk. Now that you have it, your risk is now, 2 to 3 times higher for developing, cirrhosis. And if you can avoid or abstain from alcohol, you would reduce your risk significantly. And if you can maintain a normal body weight, then you would reduce your risk significantly for liver disease progression. I think that conversation helps with the patient. But the thing is that by the time they come to us, it's not like that discussion is happening at age 20 or 30. Majority of the patients that we'll diagnose who have advanced disease are in their 40s, 50s, and 60s.
Are there other departments or other specialties that also play a significant role?
Maybe respiratory therapy, because they're getting routine PFTs. They may spend some time, depending on the involvement with respiratory therapy education. We have 2 respiratory therapists in our practice. They do a lot of education with patients, do their walk testing, do their oxygen qualifications and their lung function inhaler technique education, things like that.
In terms of screening, though it's not part of the interdisciplinary care, I think radiologists being involved in the conversation of screening, if they see certain lung abnormalities, certain liver abnormalities, they can write a note, consider testing for Alpha-1, so that could increase screening practices. I think overall, I've had good experiences with interdisciplinary communication, as long as it is within the same medical record system. Sometimes that is a big barrier. If their gastroenterologist is outside, sometimes getting consistent records, getting good flow of communication, we don't have easy ways of messaging each other if something goes wrong or if something else needs to be followed up. And so that's a big barrier from my standpoint. When they're your colleagues, I think things are a little bit easier and smooth sailing from my perspective. I assume the care of the Alpha-1 patient. And we're pretty, within our field, we're really great at coordination of care with patients that need multidisciplinary care. I assume so also with pulmonology, but we have our patients with primary immunodeficiency. And so we have to coordinate a lot with GI and other subspecialties. And so this is just a part of how we handle care. So in our institution, we're Alpha-1 center in the allergy division rather than pulmonology, so it works a little differently, but we do a really great job coordinating care. We do all the orders for augmentation therapy, et cetera, coordinate with pharmacy, and then coordinate with GI. If something else needs to be done, we directly message GI. So we're really the main person to coordinate care as opposed to the primary care doctor in that setting.
I'm a private practice, community-based practice, so we're not associated with the healthcare system, and we end up doing it all. But we're also the CRC for Alpha-1 for there's only 3 in Colorado, and we're pretty hundreds and hundreds of miles apart. So most things filter into us because of patients going to the website. They did back when they could do it on 23andMe, and they'd find out they were a carrier or they had abnormal alleles. They'd come find us through the Alpha-1 website or primary care. We've done a lot of outreach with our primary care practices about Alpha-1 education, screening, and then sending them to us. But then we end up coordinating all the other ancillary care.
Maybe one unique thing about our setting is that we're the only CRC in a 4-state area. And so I see patients that are referred from very far away. And the Alpha-1 Foundation is helpful for that as well. But as a result, I'll see people who live, I don't know, as much as 6 or 7 hours away. I'm not going to be able to see them very frequently. So I will, see them maybe annually. And then in between, the primary care physician will be the one to be managing lung disease, acute exacerbations, things like that. And so in those situations, I do try to communicate with the primary care provider. And then I think regarding kind of the hepatology pulmonary collaboration, that I think works well within our institution. So someone may be referred first to me because of lung disease, and then if I detect anything abnormal with the liver, I'll refer to my colleagues in hepatology, and we can talk easily. And then vice versa, if someone is referred for liver disease, they'll refer to me to assess for lung disease. It's a little challenging. I have a great clinic team who requests records and imaging from outside hospitals. So that's very helpful. But then when I want to communicate with them, I'll usually just try to call and get a call back, and then we talk.
The therapies that are kind of coming down the road in the next 2 to 5 years, what kind of impact that's going to have, not just on your patients, but on how you practice?
when we see our patients, again, because we're CRC, we try to talk to them about like what's going on in the pipeline and what things may be coming and that type of thing. And these patients are pretty well educated. A lot of them get involved with the Alpha-1 Foundation, so they also are getting information. So I anticipate we're going to be seeing our established, stable, augmented patients more frequently because they're going to, when they hear something's approved, I assume they're going to want to come in and talk about options, especially a lot of patients are very excited about the possibility of the nebulized therapy versus getting the infusions. Financially, I'm kind of excited about the recombinant options. That might be, something where we don't have to be so reliant on plasma donors and, cost and, reconstitution and all those things that kind of go with that. Is that going to look different with recombinant therapies? And then CRISPR, I mean, oh my gosh, how exciting is that information? And then where do we even send them and who's going to manage that? And, so there's a lot more unknown, I think, with that. But I know patients are going to have lots of questions about it. So I do anticipate volume visits are going to increase because they're going to want to have these discussions with us about, do we need to change their therapies? Could we change their therapies? Are there other options for them than what they're currently doing?
We have not been involved in clinical trials for any of the gene therapy as opposed to some of the other therapies. So I think I'm less familiar with how that will look in practice.
I think overall, this is such an exciting time for Alpha-1, right? Just as Corinne pointed out, we have all the longer acting forms of augmentation therapy, the inhaled augmentation therapy, potentially a subcutaneous or the recombinant, and then we have CRISPR technology coming that could really change the way we manage disease and be almost curative. And then we have for liver disease, we have like RNA technologies and antisense oligonucleotides and small molecule correctors. So all these different technologies in the pipelines that may really change the landscape in a big way for Alpha-1 antitrypsin deficiency. And that's incredibly exciting. At the same time, we also need to consider going back to the basics. I mean, that's so exciting for all the patients that have been diagnosed. I kind of keep on going back to, we may have about 100,000 patients in the US, and maybe about 90,000 of them have not been diagnosed. So all of these fantastic new technologies that we may have available for our patients, including potentially curative technologies, will be almost null if only 10% of the patients are diagnosed. We really need to capture these patients with novel screening therapies. And then also, going back to basics, we talked about maybe things related to liver disease. We haven't really touched on smoking cessation, some of the basics, lifestyle changes that can really be life-altering for Alpha-1, in addition to these super cool new therapies.
I think it's a very exciting time, and I definitely expect to see the landscape of therapies change in the next 10 years. But I agree with you. I mean, more important than these potentially is just smoking cessation, just, avoiding the exposures that lead to the lung disease in the first place. I guess a little different with the liver disease. Some of these things will, have the ability to correct both liver and lung disease. So, but just, being able to do a better job of identifying people who have Alpha-1 antitrypsin deficiency, and then just addressing the very basic exposure avoidance strategies, I think is still really key. Just re-emphasizing the guidelines for diagnosis. Everyone with COPD, everyone with asthma with fixed airflow obstruction, everyone with bronchiectasis, everyone with liver disease, and then, some of these rarer things too, paniculitis and ANCA-vasculitis. But I mean, just the common diseases, we are not screening like we should be. And a lot of that happens on the primary care side.
I completely echo with Dr. Pirozzi. That is the biggest barrier. We're not, even the big diseases, there's a lot of hesitance to screen widely, even though there's free testing. I don't think there's enough knowledge. So from an education standpoint, I think there's a lot of education that these free tests are available, that it's only a cheek swab, that it's anonymous, that it won't necessarily go into the medical record, because sometimes that's a fear of repercussions from the medical record. And then, what we discussed, vaccinations and smoking cessation is going to be number 1, 2, 3, 4 in terms of management Alpha-1.
Yeah. I think there may be a role for clinical decision support tool system, things like that. But it's just hard to figure out how to do it without being another notification that someone clicks away.
Thank you to our faculty, and many thanks to you, our listeners, for joining us. As a reminder, to view additional resources, please click the link in the show notes, and be sure to check back regularly for more episodes on important medical specialties topics.